we have an outstanding faculty for this 1 hour, so it's going to be full-on learning for this 1 hour procedure. And we're going to start with Femto Cataract as a procedure, and then I'll introduce the other speakers as we go along. Okay, so can we have the slides for the first talk? Okay, so I'm going to give the first talk, which is basically going to give us a little bit of a history on the Z8 femtosecond laser from a research perspective and how this has basically come into clinical practice. So this is my disclosures. I can sit. Okay, I can sit down. Okay, so these are my disclosures that you'll basically see as well. So in 2014, the Z8 was the first low-energy femtosecond laser introduced for basically cataract surgery. And there's certain key features about this laser system that differentiates from any others that are available on the market. It's fully mobile. It uses a liquid patient interface. It has an integrated OCT, which we'll talk about a little bit more later. You'll see the versatility from the other speakers as well for using basically not just cataract, but also corneal applications. It has a multi-purpose basically handpiece with an articulated basically arm, and we'll show you why this is important, especially when you have patients with different anthropomorphic features, so as deep set eyes like myself, or patients who have large noses. Then you can adjust this when you're doing basically your laser settings as well. And of course, this is only possible because it has a high numerical aperture to allow super basically focusing of your optics. So one of the things about the docking with the interface itself is that it uses a liquid docking system, and over the years it's been shown that the liquid system is far superior to using anything apart from a semi-rigid system. And back in 2015, Jared, who's over here as well, when he was my fellow, he very nicely showed in a series of experiments that you can actually drop the pressure down inside the eye when we cannulated these animals undergoing laser surgery by simply tilting the arm on your basically articulation arm by 10 degrees. And by doing that, you can actually reduce the weight down by 1/3 of the amount in the actual handpiece itself, and this will have a direct effect on the intraocular pressure. So if you're doing cases a high risk of high pressure issues, maybe patients with glaucoma or NTG, you may actually want to drop the articulation down by 10%. You can see this nicely demonstrated in this picture over here by Dennis, basically standing next to the arm piece as well. Now, one of the things about the creation of the capsulotomy, which is very different compared to other laser systems, you can see this on the right-hand side over here, you can see that the laser head is gently rocking from side to side. But when the fragmentation is occurring, you can see there's no movement in the handpiece. So you can see that with a gentle movement basically on the surface. So typically I tell the patients they're having a little bit of an eye massage during the creation of the capsulotomy. So why is that? What's the advantage basically of this itself? Well, this combined with the fact that basically you have a high resolution OCT allows you to precisely put the rexus very accurately with respect to its fixation or centration itself on the individual patient. And the OCT can help to guide you with respect to the density of the cataract, which may want you to change your settings. And we'll talk a little bit about this later on as well. We showed back in 2016 that the capsulotomy that's basically created is very accurate with respect to whether you even cover the capsule or basically you measure the capsulotomy itself, regardless of the size of the capsulotomy that's basically created as well. And the key thing with this laser system, as opposed to different to other laser systems on the market, is that the edge cut of the laser is very smooth because you're basically using that circular motion. If you measure the strength of the capsulotomy that's being created both in animal and pig eyes, you can see over here you have a very standard basically compliant ratio, which is very, very close to what you actually get in basically manual capsulotomies, and actually slightly superior in circumstances depending on the diameter of the capsulotomy that's been created as well. And that's why you see a variation in the literature when you're looking at basically strength results. Now, of course, in certain situations, okay, the cornea may be slightly thicker, like in this example over here, one of my patients with a previous transplant, a patient with a dense cataract, and a patient that you've got viscoelastic inside the eye. You can see over here, we've got iris hooks in over here itself. So in these situations where you're leaving viscoelastic in the eye, is it still possible that you can create a safe capsulotomy? So again, this has been studied in detail, and again, we were able to show that you're able to, by increasing the energy, you'll be able to get a very consistent capsulotomy with a nice, basically smooth edge, and also we're able to show very similar tension results with respect to its stretch ratio as we were able to show in basically normalized itself. So it's safe if you're doing a complicated situation to increase your capsulotomy energy to 150% without any effect on the quality of the capsulotomy to that's basically being created. So what about on the capsule itself if you basically do this? What we did is that we basically took some patients, then we increased the energy of the capsulotomy from 90 to 130 to 150, as you can see in the pictures over here itself. We then basically took the capsules out very carefully, so the reason why I'm using a lot of viscoelastic here, because they have to undergo staining. And you can see the capsular edge with respect to the amount of red cells, which are the dead cells, when you compare this at the different energy settings. And what you can see from the bar chart over here is that it doesn't matter which energy setting you're using, you get very minimal damage to the edge of the capsule. And this is important because when you look in the literature from other lasers using a microjoule energy setting itself, you'll see a very, very different picture with respect to the number of dead cells around the edge of the capsule. And of course, when you see all these dead cells around the capsular edge that we're basically removing, you can imagine it's mirrored on the actual capsulotomy that's left inside the eye. So of course, this can affect the strength of the capsule that's created, especially if you have to basically increase the energy as well. So what about OVD? Is it possible to basically create a capsulotomy if you have OVD inside in the eye? The answer is basically yes, you can basically do this. Which OVD should you basically use? Well, these are the basically top 3 that we found from our study, either Helon, HPMC, or Viscode itself. But again, the answer is basically adjusting the energy system. Which OVD shouldn't you use? Well, of course, you shouldn't use Helon GV because it affects the dispersive imaging. Not only does it affect the imaging, it also affects the laser basically threshold when it's firing through that clear environment, because you'll get more light scatter as well, and it will reduce your chances of basically getting a capsular formation. So the downside of increasing the energy, of course, is what's the effect on the prostaglandin release? And we know this, that it can basically increase. Tim's done a lot of work in this area, basically, where you get an increase in prostaglandin levels. And what we're able to show here in this study is that you can, by increasing to 150%, actually you get no increase in your prostaglandin spike compared to basically competing at 90% itself. So it shows you that not only can you increase it safely to be able to do the capsulotomy, it's not causing any adverse problems with respect to the prostaglandin release as well, as you can see on the left-hand side. And likewise, you don't get an increase in pupil miosis, basically when you have 150% capsulotomy compared to basically a standard 90% capsulotomy as well. Now, of course, clear corneal incisions, I use them all the time on the laser. Many people tell me that, you know, a lot of people don't basically use it. I think it's an excellent thing basically to have on the laser. This was introduced in basically 2015. And it works in basically more standard cases, as you can see in the video above, with the patient having routine basically cataract surgery, especially if I'm using 1 or 2 ports, depending on which lens I'm using. But even in this case below, you can see a patient of mine who's had a previous mushroom dog. By using basically the incision with a laser, you can accurately place the incisions exactly at the position that you basically want them to. And they will open up, you'll see in the videos, basically once the laser is created. Now, of course, you can adjust the position, you can adjust the angulation using the OCT once the basically incisions are created. So I think this is something that really everybody should basically be using. The incision will basically open up quite nicely. You can see on a routine case above, I simply use a cannula, a BSS cannula, when I'm opening up the incision to start with, and then you can basically insert your phaco after you basically remove the capsulotomy. And on the incision below, you can see there's a lot of arcus basically around this area, but even with that, you can still open an incision up quite easily, and I was able to easily avoid the area of basically this mushroom transplant on one of my patients, and you can basically carry on with the phacoemulsification. So corneal incisions are there, it's on the software, it doesn't cost anything more for the patient to have it, and I think it's a really massive advantage to basically have. 2016 saw the heralding of the arcuate incisions, and again, you can use the OCT to guide you with the depth of this. Rupert Menepaci in Austria has done a lot of work to basically come up with a formula from this, and this works very well. I think again, it's a nice addition to have basically on the laser system, and now this can basically be automated. If you mark the axis basically preoperatively, and in future be linked to basically the Galilee, you can actually then basically the laser will pick up the marks there with respect to where the AK incisions are going to be made as well. And you've also seen improvements in reducing the cut time with better laser lens segmentation with newer software updates back in 2018. So what's coming soon? So this is something very new that we've been testing basically on pig eyes, and we're going to start the first patients in Singapore, where basically we have a lens softening software available on lasers. This allows you to deliver a much higher energy softening procedure to the laser itself. But what we've been able to show in our preliminary results is that it doesn't increase your oxidative stress level itself compared to what the maximum is achievable in the laser. And what the laser is doing over here, it's softening the internal part of the cataract. It's on the same basically software as we see on the fragmentation, and an option comes up to basically do lens softening, and then it basically will do this after it's basically created the capsulotomy on the laser system. So you can see here the laser fragmentation is actually doing a softening block in the center of the cataract, and this is what it looks like on the left-hand side over here in animal eyes, and then next year I'll be able to show you some results in basically human patients. So the last thing I'm going to show you is some myths and reality, okay? And I've been asked to basically show this because many people have different ideas and there's many lasers on the market. And it gets very confusing when you see different lasers. I recently came from Cambridge just yesterday, and at Cambridge, it's quite interesting because this is St. John's College where I was giving a lecture, and even though Darwin basically was at university just down the road at Christ's College, you can see over here on the Cambridge logo, this is something called a Yale, which is a mythical creature. I say this is very ironic in the college or the university of the world where Charles Darwin is, you have a mythical creature on a college. Isn't that a little bit unusual? Because you've got a myth versus basically reality. Now, all of you in the room will know what this is, okay? This is one of my favorite desserts. This is carrot cake, okay? And when you make carrot cake, it's made up of certain key ingredients, and you can see this on the right-hand side, okay? And it's made up of basically flour, sugar, carrots, and obviously egg. And what you can see on this bar chart on the right-hand side is that each of those recipes of carrot cakes is slightly different, okay? The outcome is still a carrot cake, right? So if I ask you how much carrots is in your carrot cake, and you say, well, John, I'm using this King Arthur one, and I ask somebody else, and they say they're using the plain chicken one, of course it's going to be different. And I can't say my carrot cake is better than yours because I have basically more carrots in. Likewise, when you think about lasers, you cannot just take one value by itself. So you can't just take pulse energy. You can't just basically look at repetition rate. You can't look at pulse duration. You need to think about these all together because all of these things are going to affect how your carrot cake is made and how you basically get your clinical performance with the individual laser. And if there's one thing to remember that when you're looking at different laser systems in different companies. So in summary, over the last decade, we've learned a lot basically about the laser system. The mobility and the size of the laser doesn't affect basically your normal cataract workflow, and I think that's a massive advantage of using this laser system in the OT. The PI, as I said, if you angulate it down, when you basically with the liquid PI, it's shown reduced effects on pressure, and angulating it down 10 degrees will certainly help this. The nanojoule energy created capsulotomy is strong and compliant, and it gives you a smooth rexus, and you can increase the energy in those more complicated cases to 150% without any increasing in prostaglandins, and it's important to consider all of these laser parameters when you're evaluating the performance. Thank you for your attention. Okay, so the next topic is also going to be on femto cataract, and it's going to be Professor Tim Schultz, who's going to be talking about femto cataract through the ages. Thank you, Tim.
So thank you so much for having me here today, and I want to thank you, Ziemer, especially Farhad, for having me here, because it's a pleasure to working together with a company that's always interested in cutting the edge and being at the front, and I'm very happy that I'm allowed to show you our stuff that's quite new and opens new possibilities that are not able with my hands. We have to think back. What are we doing if we, and everybody of you is doing it, if we do a YAG capsulotomy? We feel it's normal, but we are destroying something. We are destroying the anterior surface of the vitreous. And so we have problems, but there's no other way to do it, so we accept them that we have them. It's an elevation in the IOP, macular edema. You can have an endophthalmitis if there's some material in the capsular bag. Retinal detachment risk is increasing, and we can have traction to the vitreous. What have we done over time? There are many IOL designs out that should prevent it, but to be honest, I don't know an IOL design that guarantees that there will be no PCO. You only have to wait long enough, and if you look into the literature, most of the studies are 12 months or something like this, and I heard a citation today that PCO needs time to grow. Yeah, we did IOL coding, and we did manual posterior capsular access, which is manual depending. So how is our anatomy? We have, at the end of surgery, if the eye is closed, we have the IOL in place. We can leave some OVD behind the IOL, maybe just a little bit, and then we have the posterior capsule, and we also can see very good visualized in the OCT the anterior eyelid surface. So what is our tool? It's a femtosecond laser. We heard it today already. That's true mobile and offers us a chance to cut this posterior capsule at the end of surgery when the eye is closed. And what's perfect for this is the low energy, the high pulse rate, and the short pulses. And we have a control before we cut with the OVT and the camera between the steps, so we can aim what we want to treat with this system. And here we are how it looks like. So the eye is closed, everything is done. The patient is uncovered. It's normally standing up, walking out, or is driven out, the OR. We still go to the laser again and cut it, and what we see is that the posterior capsule rolls up. And I was surprised when we started to doing it with the Ziemer laser, how good we were just without any special editing of the settings. And we are on a very good way to have a clear idea which settings are best to cut the posterior capsule with this system and to prevent PCO in all our patients. So there's a lot of questions behind. So we have advantages with the anterior highlight surface, and we have many advantages for the patient who might be old, coming again, having a second treatment, because as you all know, so many YACs are done around the world. And how does it look after time? So this is, I think, the only way to really prevent PCO, because we have a clear border in our adults, and this is after 2 years. There's no chance that the cells come to the middle, and there's a clear visual axis in the central. Here's another example, and in total it's a safe procedure in our experience and the data we have. We have a complete prevention of PCO, and it's surgical, not too difficult. The only thing is you have to dock a laser system, and we saw the dock and how easy it is. So here's my second part of the talk. So we came from the old patients, now we are the very young patients, and everybody who was sitting in this situation like in this second, I'm nervous, because it's super difficult. Marfan pediatric case, starting the capsulotomy. I've done in the last years over 200 pediatrics, but it's always on Wednesdays. It's still demanding for me, and I'm not sleeping so well because I'm excited how to do it. And as you know, the capsule is totally different to an adult capsule. It's much, much more elastic. So you cannot tear it like a normal one. You totally have to do another movement, and you have to train it several times to understand what's happening. And maybe this is the highest level is a Marfan eye, where it's difficult to have a good position for your Sioni ring and get the capsular bag back to the middle. And let's see how we can do it with the laser. It's not an off-label use. It has the certification for it. This is how difficult it is, and I believe most of us can do it easily in the first case, just grab it and take it out. It's a huge game changer in this eyes to do it with a femtosecond laser. I think there's no discussion about. And oh, sorry, can we see, is it a video? Yes. So, and this is how we then end up in these cases, and this is something true medical that makes me really happy to have the chance to provide for the small patients a very good outcome. We have published a lot of femtosecond laser in pediatric cases and have tested all that's necessary. I just want to give you a small peek. So as seen, the laser needs to be positioned in the OR to cut the anterior and the posterior capsulotomy. You need a full anesthesia equipment. The climate needs to be very good in this case, because it will be taking longer. You and the laser will sweat a little bit. It's a completely sterile procedure, and as you saw, we have this anatomical changes. And when we started with this, what we saw is that the capsulotomy directly gets bigger after the treatment. And what we realized, it has a direct connection with the age. So the older the patient, the less the enlargement. So we made a formula. It's published in JCRS, which helps easy to calculate how big your capsulotomy will end up. So not a Marfan case, in regular pediatrics, you say, I want to put in a Marie Tassillon lens. It should be an 89D is the name, and we will end up 4.9. Then, for example, 1 year old, you go for the formula, and you came out, okay, I have to treat 4.0 and it will end up with 4.9, and it's amazing. I'm still surprised how good this is working. And then you can put in this lens from Marie Tassillon that's totally preventing PCO in these pediatric cases. So in total, with the Ziemer laser, we have a 3D OCT that allows us all the steps. We have a reliable system. We can successfully also treat small pupils and intumescent cataracts. We have another, but my time is over, another technique, you can read it up in the JCRS for intumescent cataracts. We can treat PCO. We can do the bag in the lens with this treatment. We can do secondary IOL implantations with optic captures, and I think we're really improving surgery with this behavior. Thank you so much for your attention.
Great, thanks, Tim. That's very interesting. Some very challenging cases where the lasers really helped out. So we're going to shift gears now, and we're going to focus on the cornea. So it's my great pleasure to invite Dr. Farhad Khayat, who's going to be talking about femtocares and BLT. BLT's got nothing to do with bacon.
Thank you very much, Jod. I will be talking about different application of the laser, of Ziemer laser, where we talk about the therapeutic corneal surgery. So we had like a huge gap between the treatment options that we had for advanced and early stages keratoconus. And we needed badly new therapies that are less invasive than DALK and BK that can improve or at least stabilize the cornea, but at the same time improve the vision for those patients. And I will be talking today about two new techniques that have been introduced lately, Baumann layer transplantation and CAIRS. We know that Bauman's is the strongest layer of the cornea, and we know also that with advanced progressive disease, we have fragmentation in the Baumann layer. So Professor Milles came up with the idea of having an isolated Baumann graft and implanted into a stromal pocket to strengthen the cornea. However, this surgery did not get actually so popular. Why? Because it's the graft harvesting is a very difficult procedure. The Baumann's is strongly attached to the stroma, and it takes like 1 hour to harvest the graft. The second thing is also the pocket dissection. We are dealing here with advanced corneas that are not eligible more for cross-links or very thin corneas, and to dissect the pocket in those thin corneas is a really difficult thing to do. So we introduced the femtosecond laser to this procedure in terms of harvesting the graft. We see here on the right side, we have prepared the graft with the femtosecond laser. With the left side, on the left side, the manual preparation, we see how easy it is and how clean the cut is. On the right side with the femtosecond laser, we are struggling on the left side just to find the right plane of the Baumann's membrane, because it's really difficult, and if you go deeper, we will not be able to get the Baumann membrane. Whereas on the right side, we see the interface is very clean, and there's actually a non-edited video of the preparation. The surgery took less than a minute instead of longer than 1 hour, with 30% of graft harvesting failure and tearing in the graft. So the other obstacle is the pocket dissection. And we know, of course, when you're using the femtosecond laser, we can, and the advantage of having intraoperative OCT, we can plan the surgery and we cut the pocket at the exact side that we want. We can go shallower, we can go deeper, we can plan our surgery. And it makes a huge difference, of course, in those cases. This is the surgery. We see how easy it is to prepare the graft, and even though the cornea is almost 350 microns, and we know that the Femto has already done a good job, so we are not making a lot of effort to get this pocket dissected. So after we dissect the pocket, we have to dye the graft to make it visible in the pocket, and we just slide it on the, this is like a surgical glide, we slide the graft inside the pocket, and with the help of this cannula, we just kind of trying to unfold the graft inside the pocket. It's of course a bit different than DMEC because we don't have much of a space. So we try like to form an pseudo-anterior chamber to have more place to work and to unfold this graft inside the pocket. So I'll just move maybe forward. So as we saw, the two main difficulties that we had with Bowman graft transplantation, with the help of the femtosecond laser, we almost eliminated those difficulties. And it got really a very easy and straightforward surgery that we can do it now in less than 5 minutes instead of spending longer than 1 hour in just preparing the graft. This is the post-operative result. Actually, you cannot see the Bowman's graft in the SET lamp. Only you can see the edges of the graft. Regarding the clinical outcome, Milles and his group published this 5 years result. We have stabilized 90% of those cases. We have flattened the corneas, and we have improved the corneal or the contact lens tolerance for those patients, and thus, of course, improving individual acuity. Complication in the study, they have 10% in disseminate membrane perforation, and almost a third of the graft had failure during the preparation. Whereas with the femtosecond laser, we had 0 graft failure, and we had 0 disseminate membrane perforation in more than 80 patients. So the other technique is the CAIRS, or corneal allogenic intrasomal ring segment. It's basically ring segments that are made from corneal tissue. They are allogenic, they're biocompatible, they integrate really well with the cornea, and they were designed to overcome the complication of the synthetic segments, or even to treat those complications. Now, the described technique was a manual preparation. So we wanted to do the preparation with the femtosecond laser to have more precise and exact size segment. So, and we know we don't have any laser, femto laser that is capable of cutting segments. So we did that at the beginning. We came up with the idea of having done that within two steps. So the first step, we did lamellar graft, as we see here in the video, with the depth of the segment that we wanted and the outer diameter of the segment that we wanted. And in a second step, we duct this laser again, and we cut a smaller side cut. And thus we had a 360 ring, and then we just manually cut the segment with the scissors according to the arc length that we wanted. So Ziemer are supporting new innovations and cutting-edge therapies. So they have work on this regard, and they have introduced a new software that is capable of cutting the segment in a single step. So we don't have to duct the laser twice. With this software, we can just enter the data, the segment size, the arc length, the thickness, the outer and inner diameter, and we get that in a single step. So how the procedure looks like. And it's already cut, so we don't have to struggle a lot. So we just have to peel it. So as easy as it looks. Now the surgery, of course, we have to, it's just like the normal ESCRS. We create the tunnels, and then we introduce the segment into the tunnel. It's a bit more trickier than the synthetic segments because we are dealing here with softer tissue. So I used to mark the edges of the graft as well as the middle of the graft, just to help me locate the segment inside the tunnel, as well as like positioning the segment at the exact axis that I have planned using the digital marking systems. So about the clinical result, we see here just show 2 cases. This is the post-operative topography. We have a huge reduction in the central cornea, and this is the photos of the patient just 1 week after the surgery. Another case from advanced case to almost normal shaped cornea. And we had really a very good result with this technique. Now, CAIRS basically changes the shape of the cornea to improve the vision for the patients, but it does not actually stabilize the cornea. So we can actually combine CAIRS with different techniques to reshape the cornea, but also improve the shape to stabilize the cornea. So we can compare it actually with cross-linking. For those eyes who are not eligible for cross-linking, at least with the old protocols, not the sub 400 protocol from Professor Hafezi, I started to combine CAIRS with Bauman's graft. CAIRS to reform the shape of the cornea, improve the vision, and Bauman layer to stabilize this progressive thin cornea. So we did it in 2 steps. The first step, we implanted the Bauman graft, and the second step, the CAIRS segment like 50 microns above the pocket. This is the procedure. And the advantage here that we can use the same cornea to cut both grafts. So we cut the Bauman layer first, and then the ring segments. And then basically we do the Bauman layer just as shown before, and then implant just the segment as shown before on top of it. Just like shown before, so in the sake of the time, I'll just go forward. This is the outcome of the patient. We see from advanced case to a very regular cornea afterwards. In the OCT, we see also the Bauman's graft as well as the CAIRS segment. And this is the post-operative result, and here is the epithelial remodeling. So I will come to my conclusion. Bauman layer and CAIRS are minimal invasive, safe, and effective procedure to treat keratoconus patient. Low risk of complication. It's extraocular surgery. We improve the vision and contact lens tolerance. We postpone or hopefully avoid the need of DALC or PK. Of course, with the femtosecond laser, we're improving the efficiency of and the safety as well of those procedures. We can combine CAIRS with different procedures to get the maximum possible visual rehabilitation for those advanced cases. Thank you very much.
Thank you, Bala. That was excellent, fantastic surgery showing the combination of BLT and the CAIRS segment. Okay, so our next speaker is going to be, we always have this saying, obviously 2 is better than 1, so we're very privileged to have 2 speakers who are going to be talking about femto CAIRS. So our first speaker is going to be Professor Farhad Hafezi, who all of you will know, who will be talking about unveiling corneal biomechanics. Thank you, Farhad.
Thank you very much for the introduction. We'll split the talk in half. I'll speak 5 minutes. Emilio Torres from ELSA will speak the other half. These are our combined financial interests. Now, when we started contacting Ziemer in early 2023, we are just 90 minutes away from Ziemer headquarters by car. We were so excited about femto CAIRS because of the possibilities of improving vision in keratoconus. And this new technique that was spearheaded by Susan Jacob and then the all-femto integration by Shady Awwad would fit in perfectly into what we already had, which is corneal wavefront-guided trans-PRK and our ELSA PACE customized cross-linking. So looking very forward to it. But then, again, when I show you that, this was one of the first cuts I did in the wet lab at Ziemer's, when I saw that ring, you should know I'm a total rookie in ring segment implantation. So I'm the perfect ideal test subject. I've never used PMMA rings. And when I saw that very soft and floppy ring, I was wondering, how do I get this ring segment into the cornea? Especially since, following Shady's footsteps, you keep the tunnel as tight as possible to have the maximum of effect. So I asked myself that question, how do I get the ring segment in? The second question, I have a cell biology background, so I asked myself, these eye banks, do they ever test their donors for keratoconus? Or will I cut a ring segment with keratocytes from a donor keratoconus patient and implant these keratocytes into another keratoconus patient? And I didn't like that idea. And indeed, the eye banks cannot check for keratoconus. So what if my donor has keratoconus? And lastly, what in fact flattens the cornea? For sure, the depth of implantation and the dimension of the tunnel, but then we were wondering, is it the volume of that ring segment or maybe the intrinsic stiffness of the ring segment? Now, going back 10 years, we were looking a lot into biomechanics of cross-linking. And I had an MD PhD student that was working on that paper, Olivier Richaud, and one morning he accidentally left the lab. At that time, the cross-linking machines didn't have a timer. It was just running. He left the machine running for about 8 hours, delivering 60 joule to a cornea. And when we came back to the lab, this cornea looked like a piece of plastic. It was super stiff and super hard. And having this in mind, what happens if we get a very, very stiff ring segment? So cross-linking the ring segment before you insert it. And then you are not limited to any endothelial damage. You're not limited to 5 joule or 10 joule. And this is more or less the maximum we do in a human cornea. You can go way higher. And this is what we did. So we cross-linked that ring segment before inserting it. And we used up to 60 joule. And that's almost 10 times, no, more than 10 times the energy of the Dresden protocol. And what we have now are preliminary stress strain measurements, and indeed the cornea gets super stiff. And not only stiff, it doesn't swell anymore that quickly. So you can put it into water and it will remain the same size for several minutes. And that's a huge advantage when you want to put the ring segment in. So we call it, for now, ADA CXL, from Adamas, indestructible, Greek. And why performing cross-linking on the ring segment? Well, as I said, it's extremely easy to insert. My learning curve was very steep because I had the easiest time to get that ultra-stiff ring segment into the cornea, into the tight tunnel, and nothing lives in that cornea. Every single cell keratocyte is dead. It's just a collagen scaffold. And whether the flattening corresponds to the degree of stiffening, yes or no, this will be responded to in part in the second part of the talk that is given by Emilio Torres. Let me just show you how we cross-linked the tissue. So the entire procedure is a mirror of what you are doing, Shady, with one exception, which is now the imbibition and the ultra-high fluence cross-linking. Now you would see how super stiff these ring segments become. So this is actually my doing. I think this is the third or fourth ring segment I've ever implanted, and it was very easy to get in. Even the last 20%, which usually are hard due to compression. Emilio, would you like to take over? Super. Here comes the second part.
So, good afternoon, everyone. I'll just keep, oops, go to the next one, please. So just keep going then with the Femto CAIRS. Good afternoon, everyone. And so starting corneal ring segments were for sure innovative procedure, and I'm sure that now the Femto CAIRS is the evolution of the rings. That's thanks to Susan Jacob and Ziemer together with Shady that put this technology into the femto laser. So here you saw before already how we, let me come back, how we perform the procedures. And the important here is that we are able to use the OCT. So that's a very nice tool that the Z8 has, so we can precisely know at which depth we are, and that's another layer of security we have, safety we have. So from the beginning, we started, as Farhad showed, to implant the corneal rings after the Femto CAIRS already cross-linked. And here is another perspective, another case we had. Also, you can see after a short learning curve how easy it is to implant the corneal rings. Then the results here, just one day after the surgery, we can see a nice improvement of the surface, improvement of astigmatism, and then of course we had some questions. This is just a day or 2 days after the surgery. You see also how the surface heals very quickly using Femto. That's just 3 days after. There is no signs of erosion and a little bit of corneal edema. So that's the OCT image the recovery is very quick as well. And then, seeing some of the results, I was asking myself as well, how is the result? Does it correlate with the synthetic rings we had? So this is an example just 3 days after, in which you have a huge central flattening of the cornea. And then comes the biomechanics. So do they work similar, a femto-CAIRS and a synthetic ring? Well, to try and start answering this, we used the OCT elastography, and just for those who are not used to, the elastography makes a deformation on the cornea, in this case with eye pressure change, and then we are able to analyze the strain of the corneal tissue. So we did this before already with synthetic rings, and just take attention to one color here in the central red color, that means strain changes. So when we implant a corneal ring, a synthetic corneal ring, we see those changes in the middle. So the cornea here was relaxed, and we tested this with many sizes. So repeating our experiment now, we did also with femto-CAIRS, so using the Z8, again, here is the video, again the OCT guided, and then we implanted the corneal rings also with the jerky technique, so let them dry, and then evaluate them on the OCT elastography. Here the results, you see the cornea, that's a normal cornea without any corneal rings, without any strain modification, or actually this blue means a compression of the tissue, which we would expect. So do you remember that red we saw before? We don't see here. So that's the normal behavior of a cornea. And now with femto-CAIRS, 120 arc length, still very similar to a normal cornea, so no significant strain change, although we did have a high flattening, so a huge flattening and no significant strain. In the same, we observed with 160 arc length and also with big arc lengths to 10 femto-CAIRS. So in conclusion, the Z8 provides us the precision of customization, and on top of that, using the OCT pre-op, which is amazing and increase our safety. Looking to the biomechanics, the femto-CAIRS did not cause any unnatural corneal deformation that was different from the synthetic rings. Therefore, we might here have less extrusion risk. Surgeon Jacob already proved this clinically, but here is a study ex vivo as well. And there might be a role here in the astigmatism correction between those techniques. And finally, the tissue addition on the femto-CAIRS is likely the main factor, not the forces or the strain distribution changes. Thank you very much.
Thank you, Emilio.
And that's our team that was involved. Just thank you, everyone. The photo is there as well.
Great. Thank you, Emilio. So we're going to move to our last topic. Now we're going to shift gears again now to refractive. So it's my great pleasure to invite Dr. Rajesh Fogla from India, who's going to be talking about his initial experience with CLEAR. Thank you, Rajesh.
Good afternoon, everybody. Now, CLEAR stands for Corneal Lenticule Extraction for Advanced Refractive Correction. It's a lenticule or a CAIRS procedure.
One of the latest products is CLEAR, a cutting-edge laser refractive procedure.
This is an animation provided by Ziemer that gives you a basic of what the procedure does.
Extraction. It works seamlessly with the Z8 platforms, the solution for guided refractive surgery.
I think in the interest of time, we'll move to the surgical video where you'll be able to see this. The advantage of using the Ziemer Z8 laser platform is that during the procedure, you have centration options. You can, even after you've finished your docking, you can shift the position, you can compensate for the cyclotorsion, you can have the pupil centration on the cornea or onto a fixation light, and you have the guided extraction where the incisions that you make can be can be linked to the anterior cut or the posterior cut, so you have easy finding the planes of your lenticule. You have the low energy overlapping pulses that ensure that the minimal tissue damage, and you have the compact hand piece, which is very easy to use and very comfortable for the patient. So that shows you the different centration options. You can make incision on the left side, right side, or a dual incision. Usually when you start, we start with the dual incision. That's showing you the two planes, the anterior and the posterior, and the guiding tunnels. And you have the advantage of having the OCT intraoperative. So once you apply that, you can visualize it and ensure that your lenticule is within the applanated area, and the guiding tunnels are ideally where they are supposed to be. We spoke about the low energy pulse, and the best part is the articulating arm. So it's very comfortable for the patient, especially patients with deep set eye or patients. You can really position the head and you can easily dock rather than bringing the entire bed to the laser, unlike the other laser systems. Now, when we do the procedure, the interface is very nice. You can put in the parameters like the keratometry, the Q factor values, the pachymetry values. You can adjust the sphere, cylinder, and the axis. It's a very user-friendly software. There are nomograms that help refine the outcome of the procedure. So you can, depending on the nomogram, you can adjust the target refraction and the adjustment in the sphere or cylinder that you need to make. When we started off, we were using the procedure without our nomogram, but once we started using the nomogram provided, our refractive outcome became much better. So you can see that you have those 3 marks, which ensures an automatic centration once you dock. And then you can see that I can shift the lenticule position to the pupil. So this is possible if you want to, and it automatically compensates for the cyclotorsion. And in future with the Galilei link, this will become even more automated. So you can see that's the posterior cut being made first. And the patient is very comfortable during the entire process, and because of the docking that happens, suction loss is almost negligible. The risk is like in our initial experience that we have done, we have not experienced any suction loss in any of the cases. And we have not even seen any OBL or anything that we hear about from the other laser. So you have the anterior and the posterior plane that's been done. That's the cut. We used a single incision here. And you can see that during the procedure, finding the anterior plane is very easy. And the dissection is also seamless. You don't have to apply any kind of pressure. We do need to optimize the laser energy compared to what you get when the laser is installed. You can always modify that. And that's a relatively unedited video. You can see that's the posterior plane being identified. And if you have a cooperative patient, you don't even need to hold at the limbus, but when you're starting off, it's always better that you stabilize the eye and then do this procedure so you don't end up creating any kind of flap tear at the edge of your incision, especially when you're dissecting and if your patient is not cooperative. And if you make a thinner flap, that risk is more. So once we have done that, you can easily grasp the lenticule and you can pull it out. You can see that it's fairly easy to perform. And we just like to irrigate the interface with a little bit of BSS just to ensure that all the fibers that's been separated, they kind of fall back into place. I don't really try to squeeze the surface. We just remove the speculum and that's again to show you another similar procedure, but we will move on. That's how it looks on day 1 post-op. You can see the cornea looks very clear. And if you see on retroillumination, you don't see too much of irregularity, which is quite comparable to the other laser system patients that I've seen in my practice. You can see that's the pachymetry, very well centered on the anterior segment OCT, and you can see the result. You can see very well centered treatment zone, and if you see on the AR, the values are almost plano. That's another case. You can see pre-op minus 3.5, post-op very well centered. And if you look at our outcomes of the cases that we have done initially, without the nomogram, we had the initial 5-6 patients, but still then we have almost 67 persons who were 20/20 or better. And now after optimization of the laser system, this has increased to almost 80 to 85% of our patients see 20/20 or better on day 1. I'm sure Shady will be sharing a result which give you much more long-term outcome. Besides that, in our practice, we do use it for LASIK, where it makes very predictable flap. both in terms of the thickness and the dimensions. You get very large diameter flap, very easy to lift, and a very smooth interface bed. So it's revolutionized our LASIK practice, where we've almost given up doing microkeratome LASIK. We do use it for corneal transplantation, where we do it for the laser helps create the big bubble technique much more easily. And if we still do the intracorneal rings and both the femto CAIRS. So it's very useful in both of these procedures. So you can either use it for the conventional intracorneal rings, or you can use it. So here is the technique when we do our femto CAIRS. We basically, instead of drying or instead of cross-linking it, we can use a metal template ring that we introduce into the pocket. It has 2 openings on either side, and we can suture the stromal segment to one edge, and then we can really just rotate it, and we get the segment into the pocket. So we don't really need to make much wider pockets. We are able to get a very nice tight fit and a great outcome. So that's how it looks, between the difference between the stromal segments and the intacts. And we, just like Badr Khayat spoke about the lenticule insertion, we use the laser also to perform lenticule insertion. And that's how it looks post-op after putting in a cross-link stromal lenticule. And definitely we use it for our cataract practice, and it's very easy to use because the machine is so small, it can just be wheeled into the OR and you can perform the procedure. So for learning curve, clear is very easy for somebody who's never done a lenticle extraction. With this laser system, you will seamlessly get this into your practice. However, case selection is important. Don't go for very low myopia or very high refractive errors. You need to optimize your laser energy and gentle dissection, and with consistent technique, you can always have a great outcome. And in our practice, besides using for the refractive lenticule extraction, we use it for flaps, for astigmatic keratotomy, post-keratoplasty, for ring segments or stromal segments, cataract removal, for corneal transplants, and even for surface reconstruction procedures, as George has shown that it can be used for pterygium surgery or for limbal stem cell transplantation. Thank you for your patient hearing.
Thank you. Great, thank you, Rajesh. That was fantastic. So it's my great pleasure to invite my good friend Shady Awwad, who's going to be talking about excellence in lenticle extraction, clear using the Z8, from an excellent speaker and presenter. Thank you, Shady.
Thank you, John. Hello, everybody. Last talk, but I promise it will be fast and on time. So I think the Z8, and everybody would agree, the Z8 is the perfect platform to transition from femto-LASIK to lenticle surgery. It's very forgiving, impossible suction loss, which is a nightmare for everybody. Very low possibility of OBL or of shadow treatment with bridges. But how to take that procedure to the next level and really achieve excellence in it? Let's first take a look at the results now, 1 year result, and I'm glad to share with you the 1 year results with clear. The demographics were 102 patients with minus 4.11 MRSC, extending all the way to -9, -10, and with a cylinder of -0.5, extending to -3 at the max. The cap on the average was 130, from 110 to 140 ranging, and optical zone was 6.6, ranging from 6.3 to 7. By the way, the dropout rate for this study was 5% only. So those are patients really followed and meticulously over 1 year and called and reminded for their follow-ups. So if you look at the post-operative UDVA, it's a whopping 96.7% 2020 at 1 year, with 51% 2016 or better. If you look at the CDVA, 40% gained 1 line and only 5% lost 1 line, which is actually comparable to the best platforms of both lenticle and femto LASIK. Spherical equivalent refraction was actually very good, with most of them sequestered within plus or minus 0.5 for about almost 97% of patients. The stability of the spherical equivalent refraction is amazing, and I'll talk about it in a minute, but you can see how it's stable all through up to 1 year, not much of a regression at all, even though the cohort included very high myopes. And the attempted versus the achieved is also, dead on the center with no outliers. The aberration profile, it looks really good with almost minimal induction of spherical aberration, known that we have up to -10 diopter of spherical equivalence within the cohort, and minimal induction of horizontal coma. So now, if you look at the astigmatism sub-analysis, and I think that's important because only 3 papers address that in an appropriate vector analysis when talking about lenticle. The first one with Zhang et al. Back, and then the other one with David Kang with Dan Reinstein looking at the 3-prong marker on the Visumax 500, and another one for Dan Reinstein looking at high myopes and doing a sub-analysis of vector of the astigmatism. Now, our analysis showed, as you can see here, over 12 months, a really good 97% of patients were within plus or minus half diopter of the final treatment. The target-induced astigmatism versus the surgical-induced astigmatism showed not much of an outlier, only 1 patient with 1 diopter of induced. And the angle of error was pretty tight. The rest were actually patients who have 0.25 diopters, so they kind of vary, with a larger range of angle error. But for the bulk was really dead on within plus or minus 10 degrees. And you can see here the centroid going really centered dead on with 0.01 centroid with plus or minus 0.29 on the standard deviation. Now, if you look at corneal tomography, that's a patient with a -4 diopter of treatment. So that's the tangential curvature. I love tangential curvature because it doesn't lie. It doesn't smooth out things like axial curvature. So you can really see what's happening and what are the irregularities, and that's the other eye as well in 6 months. So if you look at day 1 and at 6 months, nothing happened. It's pretty stable topography. To understand that, let's take a look at the epithelial map of that very same patients with a -4 diopter of treatment. So if you look at the epithelial map, what strikes you is the following, and that's what I expect for a perfect lenticle surgery in general. I mean, that's not only new for clear, that's what I expect in a perfect lenticle surgery. So if you see for a -4, for a femtoLASIK, I expect a thickening in the center as compared to the periphery, and that by itself is the one that actually will produce regression over the next 6 months to 1 year. So what you see here is actually 53 as an average done with the OCT machine at 39 and 51 at the mid-periphery compared to 58 in the center and 60 at the mid-periphery. Of course, it's a -4, it's not a -10 or a -8. But that tells you, if we plot that for all the patients, that tells you that actually the curves have shifted a little bit with actually just a little bit more thickening in the center than the periphery for moderate myopes. Of course, that is much less, and actually it's reversed when you go higher up. But it tells you that one of the key elements why we like to see post-femtoLASIK patients with a -4, we like to see a little bit of hyperopia because we know that's on day 1, because we know that's going to regress over the next 6 months or so. Not the case in clear or in any perfect lenticle surgery because that's going to be stable all through because of that epithelial remodeling effect. All right, so now the next thing. We know the laser works great, but how to achieve the first day wow effect? So in order to do that, what I started to look at is actually the interface quality of the lenticle. And I use a machine, which is a pyramidal aberrometry by CSO, whereby it gives me like a kind of a retro-illumination without any artifact. And I look at it, and that's a pre-op. It's like a backscattering effect. And then I look at some of my patients who did not do very well on the first day. They were like 2040, 2050 first day. And then got to 2020 and that was with my early stages when I started. And that's what I see. You see like a mud cracking. And I research and I ask my colleagues, and that's what I get even with other platforms sometimes. And we didn't know how to improve that. These are some patients with, as you see, it keeps getting better, and by 6 months it's almost gone. By 1 year it's gone completely. So we developed an algorithm based on image analysis to understand what's going on. So we called it the homogeneity score. So what the homogeneity score does is automatically gives you a homogeneity of the whole interface, and a nice one would be 0.84, 0.85, that's an untouched cornea. A bad one would be 0.72, for instance, because the homogeneity is less. And by having that, I have a number that I can every time tweak and understand what I'm doing and how it can improve my first day result. And that's the holy grail of all lenticle procedure, and every center is different. I'll tell you why. What I discovered is that the one thing that helped me a lot is 1, lowering the energy, and 2, doing this step, which is making the lipid tear film homogeneous. So I rotate the eye, irrigate forcefully, get everything out. If needed, I use a wet Wexel just to redistribute the tear film. It's wet, so I'm not drying the cornea, it's just redistributing the tear film, and more importantly, the lipid layer of the tear film. Now, why is this more important? I don't push for everybody to use that Wexel procedure, but at least to irrigate forcefully while the eye is rotated outward, while the whole head, because it makes sure that the lipid is well distributed, the lipid layer in all your cornea. I also make sure that I shield my meibomian glands. This is a low energy laser, and if you have an unequal tear film thickness or unequal tear film distribution, is going to create more scatter with the treatment. And I actually learned that from my other colleagues on other platforms. So that's not something unique in one laser. That's actually the basis of femtosecond. Somehow nobody talks a lot about it, but that's what I learned from my colleagues as well. And when I applied it and I checked with the homogeneity score, I saw this is one of the patients, huge change at one day. And by 1 week, it's almost there. His homogeneity is 0.82 or 83 even. So when I compared them together, my old technique, the usual one without much of that irrigation and painting, to the new technique now, there's a huge difference, and the P less than 0.001 between the old technique and the new one in terms of interface homogeneity. So food for the thoughts are the following. No two lasers are similar, every laser is different. And exactly, not every Z8 is different, not any other laser are different. You need to know your laser. Start with the energy that is comfortable to dissect, because high energy is easier to dissect but has a very low visual recovery on day one. And then slowly, as when you pick up confidence, slowly move into a lower energy, yet still acceptable dissection and a great first day visual recovery. And bear in mind that not every patient is the same. What works for one patient, you need to wait a little bit before you decide to lower the energy more, because everybody is different, and more importantly, not all populations are the same. You might be in an area with more crusting cornea because of high UV light, and then bear in mind that when you perform your treatment. So finally, the keys for success, of course, adequate markings. Now that the Galilei is linked, but not yet officially, but it's actual link, hopefully that's going to be much faster for us and more accurate. Make sure your optical zones are large, but not too large, because that's going to add a lot of energy. Make sure you have a good depth, but not too deep of a depth, because dissecting deeper in the stroma, you need more energy to do that. So a 130 is a happy medium, and I can move now to 120 if needed. And more importantly, slowly settle to the lower energy, and make sure that your tear film is really homogeneous in terms of lipid layer. Shield your meibomian glands as much as possible, and make sure your tear film is homogeneous. And that's why you can get really extremely safe and extremely effective results with the clear procedure. Thank you.
Thank you, Shady. Great, thank you very much, Shady. So, I mean, I think we've seen a fantastic array of speakers. I've learned a lot in the last hour, and I think it's like a full-on tuition lesson. So if you have any questions, please approach either at the Ziemer booth or any of the speakers after the session. I want to thank all the speakers for their fantastic presentations and keep them within 1 minute of time. And I hope you enjoy the rest of your meeting in Barcelona. Thank you.